Good morning, everyone. Welcome to our November edition of High Rounds. And a nice little hello from Ryan, who I'm sure is very excited about this. Anyway, welcome, everyone. I feel like I say this probably every time that I'm really excited about this talk, but this is really, I think, a talk to listen to because this is a very new and emerging data from our very own Owen clinic, which has some of the now most robust experience using long-acting Cabotegravir and Rilpivirine. So I will introduce Lucas quickly so that he can get to it. Dr. Lucas Hill needs no introduction, but I will give him an introduction. He leads the clinical pharmacy team at the Owen Clinic, and he's an assistant clinical professor at Skaggs School of Pharmacy. I hope that's changing someday soon. Completed PharmD at the University of Southern California and then residency at UC San Diego in 2012, specifically coming here to work with Craig Ballard and others at the Owen Clinic. After residency, he led clinical pharmacy services for the hepatitis C monoinfection clinics at UCSD, and then was also helping out in the co-infection clinic. And then he came over and fortunately landed with us and has stayed there. So I haven't asked people this in a while, and I don't know if Lucas remembers the fun facts that he gave me last year when we were doing fun facts, but it's going to come again. So he took a year off before pharmacy school and worked at an antibody production facility in Pennsylvania. The lab was located on a farm where they raised animals to generate the antibodies. And this is where he met his wife. So it's it's fun when you go off into antibodies and then actually end up meeting the person you'll spend the rest of your life with. And then maybe Lucas will say something about the Phillies because that's been very fun for him. Anyway, I will pass it on. Oh, yes. Diehard Eagles. I wouldn't need to talk about the Eagles, Dan. But yes, Philadelphia is having a great sports year. But Lucas, I'll turn it over to you. I'll keep an eye on the chat and we'll try to keep things on time so we give people time at the end.
All right, thanks, Jill. I'm going to leave the Phillies because it's kind of probably raw for Padres fans, but sad that they lost last night. I hope they can turn it around this weekend. And then the Eagles are the Eagles. I think they speak for themselves. So I'll get started. I'm really happy to have the chance to talk about this topic. We started our first patient on long-acting Cabotegravir back in May of 2021. So it's now been about a year and a half of experience with this. And I'll be honest, when I started putting this together, I had a lot more stuff to talk about, but it's just not enough time to go over it all. So I'm going to try and just talk about some of the newer data we've kind of put together from our patients. I was going to kind of go over some updates on the evaluation and initiation process, and kind of especially focusing on what we've been seeing for resistance testing in patients who are interested in Cabotegravir, but there's just not enough time. So if you are interested in any updates in that data, we did present an abstract on that at the AIDS conference, and hopefully will be published soon. It's in review. So I'm going to focus more on kind of the next steps in the process, which is kind of go to my next. Those are my disclosures, which is kind of just a general overview of who we've started on long-acting Cabotegravir at the Owen Clinic, and try and compare some of those characteristics to our general population of people with HIV. Talk about who stopped, and kind of compare those that have stopped and versus continued Cabotegravir, and then spend some time on our viral load outcomes so far in our patients on therapy, and try and kind of start looking at what are some potential predictors of detectable viral loads after switching to Cabotegravir. Describe our one virologic failure that we've had so far, and then kind of wrap up in talking about using Cabotegravir in patients who are viremic and not adherent to oral ART, because I think that's a popular topic right now and something that a lot of people are interested in as an alternative way to use long-acting injectables. Okay, so just move some things out of the way so I can see the slides. So this is a kind of a summary of all the patients that we've started so far on long-acting cabotegravir. I think this data is up to date as of mid-October. And so we've had 651 patients who have expressed interest and kind of are in different stages of the process of being evaluated for starting or had decisions made on not starting. But of those, about half, we've started 319 patients on long-acting cabotegravir. I think now, kind of currently, we're closer to like 340. But we're, kind of right at around 10% of our entire clinic population now on long-acting or that have tried long-acting injectables. So it's a large group of patients, and it continues to grow. And so of those 319 that have started, we still have 285 that are still on therapy, and 34 patients, or around 11%, stopped therapy or left the clinic while on therapy. And so I'll talk about some of the reasons why patients have decided to stop. And then below that, on the bar graph, I kind of just tried to put together to give an idea of kind of the trends over time in terms of how many patients we've started. And you can kind of see, and I kind of broke it up into quarters over the last year and a half. And you can see that it took till around the beginning of 2022 for things to kind of really get going. The first half or second half of 2021, we started around 30-40 patients a quarter. And then from there, it's increased steadily. In this last quarter, we've started over 100 patients. So we continue to see a lot of interest. And the numbers haven't really started to level off even yet or slow down. So I just wanted to kind of show what the characteristics are of the patients that started and compare them to kind of just the general Owen clinic population. So if we look at age, our median age for those that started cabotegravir was 41. And it's a wide range. It's ranged from 20 years old to 83 years old. And it's a younger population than the entire Owen clinic. The median age at the Owen clinic is 53. In terms of race and how are we doing in terms of I guess equitably helping access this therapy for those that want it. Interestingly, for those that started cabotegravir, 47% were white and 20% were Black. And that's different than the Owen clinic, in which 53% are white and about 12% are Black. And so I think you can maybe just hypothesize as to why we have more Black patients who have started cabotegravir. And I think one of the biggest things, maybe anecdotally, is stigma. And I think, there is, greater stigma among our Black patients. And I think, this opportunity of being on injectable therapy and taking away the issue of daily oral therapy and having to hide medication and things like that is a big deal. So that might have something to do with it. Similarly, we have a slightly higher percentage of patients who are Hispanic that started cabotegravir, 38% versus 32% for the Owen clinic. And then also, when we look at sex assigned at birth and gender identity, 15.7% or 50 patients who started cabotegravir were female assigned at birth. And that's compared to only around 9 or 10% of the entire Owen clinic is female assigned at birth. And so, again, all I can do is hypothesize as to why that is. But, and also, just in terms of talking to patients, I think some of the things that contribute to that probably, we have a fair number of our female patients who were recently postpartum that have expressed a lot of interest in cabotegravir for, I think, obvious reasons. And so that probably contributes to this. And then also, Karen had talked about it a little bit at her high rounds, but our Haitian refugee patients are also very really like the idea of long-acting injectable therapy. And again, I think that relates back to stigma as well. And so we have a fair number of female patients in that group as well that have started. Looking at our trans non-binary patients, it's similar to what we see at the Owen Clinic, around 2.2% that have started Cabotegravir. And then other factors, almost half have Medicaid insurance that have started, and about a third have commercial insurance, 6% with Ryan White ADAP. I have the gross numbers of, I didn't have time to totally do the breakdown on the insurance for the entire clinic, but I think it's probably somewhat similar. And then for regimens at time of switch, the majority have been on second generation integrase inhibitors when they switched, at 60%, and then about 14% on 2-drug regimens before switching. Our median BMI is 26.8, and that ranges from 16.9. The highest BMI that we've done so far is 44.9. The median CD4 count for patients that have switched is 720. 76% have been less than 20 at the time of switch, 89% less than 50 copies at the time of switch, and 3% have been greater than 200. And I'll talk a little bit about some of our experience using it in viremic patients. We don't have a huge number, but a few. And so far, the median follow-up time for all these patients has been about 180 days. So I mentioned that about 10% of patients have stopped, which is 34 patients. And this kind of shows the reasons why. So 35% stopped due to pain secondary to the injections. 17% or 18% kind of decided they weren't able to consistently come in for the injections. 18% have either moved or transferred care since they started here on Cabotegravir, and most of those, if not all, maybe have continued at the other places that they've gone to. We've had 3 patients with other side effects that have decided to stop. Most of them may have been unrelated. The first one, unrelated facial swelling. And this was something that was going on before they started Cabotegravir, but the patient decided they didn't want to do it anymore. We had one patient who went direct to injection and got 1 injection and had hives and pruritus afterwards. But she was also dealing with issues with hives prior as well. So it's not clear if it is really related, but the decision was made not to do the next injection. And then one patient who felt it was causing GI side effects and decided to stop. 2 developed hepatitis B, detectable low-level hepatitis B viral loads after switching, and I'm not going to go into detail because I think Darcy's going to touch on it in a couple of weeks at her high rounds, and we've presented some of the information about that. One patient has died. We've only had one patient so far completely lost to follow-up that we haven't been able to track down after they received their first injection. One has been incarcerated, one stopped due to a change in insurance, and then one patient has become pregnant and stopped. And so kind of tried to look at what is the norm or the trend towards, how many injections before patients have stopped. And you can see the majority decided to stop with either the first, second, or third injection. And then kind of a spread between 4 and 14 injections for some of the others. But most patients, if they do decide to stop, it seems to be earlier on after the first couple injections. And so, thinking about this, it's a small number of patients who have stopped, but I was trying to look at maybe was there, what are the characteristics between those that have and have not stopped, and kind of try and compare them. So roughly put together. Yeah.
Lucas, there's already a few questions.
Sure.
The people who stopped for pain, were those the ones who started with monthly injections?
I don't have a breakdown of who stopped monthly versus every 2 months, but we've been doing every 2 months for quite a while, and so many people now have started every 2 months. I can't say that it was definitely monthly injections that was the majority.
Okay.
And I was going to say, I just asked because I had a patient who started with monthly, then went to every 2 months once that was approved. And I think the volume is more, and so they experience more pain. And so I don't know if they're used to monthly injections, that volume, and then, every 2 months, if that was a factor.
Yeah, good question, Darcy. Anecdotally, I have not seen many people who stopped with the switch from Q1 month to Q2 months. So that's probably more of an outlier.
And I don't think the studies, reflected that either.
Yeah. Yeah.
The death person, sorry, the person that died, not related to the drug.
Yeah, unrelated. Yeah.
Okay. Lalo, this was from the slide before. Older people living longer with HIV may have increased stigma, but people who started were younger. Have you looked at time and care or when the HIV diagnosis was? That might be something to consider.
Yeah, we haven't looked at time and care, but one thing we did look at just in terms of those that did and did not start, because that's something that we've evaluated. Age was actually a significant predictor in the multivariable analysis, or I'm sorry, in a univariable analysis. So those that started were younger, those that did not start were older, and that maybe, one thing I was considering is older patients may have a higher likelihood of resistance as well. And so maybe that's another reason.
And then are you going to talk about the two hepatitis B people, or is that something that Darcy's going to do?
We've had 3 patients with low level detectable hepatitis B viral loads after switching who were core positive, surface antigen negative. And Elliot presented that data at ID week, and Darcy's going to touch on the specifics of that in a couple of weeks.
Were they surface antibody positive?
I believe 1 out of 3 was surface antibody positive. The other 2 were surface antibody negative.
Were they boosted before starting Cabotegravir?
No.
I think this will be a good discussion next week because it's interesting for sure. And then Shannon writes older patients have more oral meds too, so maybe it's less of a priority to switch since they're doing it anyway. And I think there are lots of reasons.
Lots of reasons. Yes, I agree.
Okay.
All good points.
All good thoughts. Thank you.
Yeah. So, comparing those that did and did not stop. So for those that were included in the analysis, those that stopped, I included everybody except those that stopped due to moving or changing healthcare systems. And so that would bring it to a total of 28. And then for those that were included, since most people seem to stop within the first, 3 to 5 months of injections, included all of those that had continued for at least 4 months on Cabotegravir. So that was 179 patients. And just kind of looked at factors. I compared the different factors that I've already discussed. And the one thing that kind of came out as significant, both in the univariable and then after doing logistic regression, was female gender identity were more likely to stop. So identifying as female had increased odds of 3.37 of stopping Cabotegravir. And I'm not exactly sure why that is. I did try and go back and kind of just do a look at specifically why our patients who identified as female stopped. And I didn't see really any trends. It was kind of very mixed. And so although I think most were side effects, but most of everybody that stopped was because of some sort of side effect. So it's hard to say, but I think it's interesting and something to kind of consider moving forward. Okay, so I'm gonna now kind of move on to some of our virologic outcomes. And what I really wanted to try and focus on was our patients who have had viremia post-switch. And I think, looking at, because, I think one thing that we've been thinking about with this therapy is our patients with persistent viremia on oral ART, not necessarily high viral loads, but persistent low level viremia or frequent blipping. And if you take away the issues of adherence and absorption and you move to injectable therapy, do you see improvements in that? And that's kind of one thing that we really kind of wanted to see if we could focus on and kind of start to answer that question. And so before I look at our data, this is just from data from ViiV from their phase 3 trials, looking at the frequency of blips for patients that were on study with Cabotegravir. And so they looked at data from Atlas, Flare, and Atlas 2M, which is the every 4 or every 8 week trial. And they looked at all viral loads at the different study visits through week 48, and they compared the blips on people that were on the injectable arms versus on the oral therapy arms, and then every 4 versus every 8 week injectable. And they defined a blip as having a viral load basically between 50 and 200 copies. with an adjacent viral load of less than 50. And then they did point out that of the 17 confirmed virologic failures in the studies, there was only one that had a blip before reaching confirmed virologic failure. So no association between blips and failing. And then the figure basically shows that there wasn't really a difference, between oral therapy, injectable therapy every 4 versus every 8, and frequency of blips. It seems like at every study visit, roughly between 1% and 3% of patients would have had a blip. So, we tried to kind of take a subset of our patients that have started therapy and kind of look at what virologic outcomes we've been seeing. Kudos to Nimish for helping with the analysis, and then one of our pharmacy residents for helping collect the data. But we did a retrospective review of those on Cabotegravir for 3 months, at least 3 months, that had available pre and post-treatment viral load values, and then had at least one viral load collected more than 21 days after starting Cabotegravir. And we characterized the patients both based off of their pre-switch viral loads. We looked at all viral loads 1 year prior to switching and put them into a pre-switch category, and then looked at all viral loads after switching and then put them into a post-switch category. And so the categories were defined as they had blip, which was defined as at least one viral load between 20 and 200, followed by the next viral load being undetectable. Persistent low-level viremia, which was at least 2 consecutive viral loads between 20 and 200. Our high viral load group they had at least one viral load greater than 200, and then the suppressed group had all viral loads less than 20. And for this initial look, we did use 20 as the cutoff. We have parsed out between 20 and 50 as well, but the numbers start to get small. And so the analysis included 144 patients, and the median duration of follow-up after switching to Cabotegravir has been 131 days. So first, out of that 144, we took a subset of 116 that were suppressed, less than 20 at the time of switch, to look at maintaining suppression. And did a time to event analysis of the probability of remaining less than 20 after switching. And so the solid line are those that had at least one viral load greater than 20 in the year prior to switch. And the dotted line are those that had all viral loads less than 20 prior to switch. And you can see that being continually suppressed in the year prior had a higher probability of remaining suppressed after switching, and vice versa, and that was significant. And then also looked at the factor of having multiple consecutive viral loads greater than 20 in the year prior, and that was also associated with an increased probability of having an on-treatment viral load greater than 20, so 47.6% versus 23.2%. Which was significant. And so I think it starts to speak to, if patients are having detectable viral loads on oral therapy, they have a higher likelihood of having detectable viral loads after switching. And then this is still kind of in process, but I was trying to kind of evaluate, were there other factors associated with having elevated viral loads after switching? And so, as I mentioned, we had 116 or 80% that had a viral load less than 20 at the time of switch, and 91% that had a viral load of less than 50 at the time of switch. And we looked at these different characteristics as prudential associations with having viral loads that were detectable after switching to Cabotegravir, and did the analysis at first looking at those that had at least one viral load greater than 20 after switch, and then again, at least one viral load greater than 50 after switching. So when you look at those that did and did not have a viral load of greater than 20 after switching, the factors that were significant in the univariable analysis was essentially having a detectable viral load at switch, and then also having persistent low-level viremia pre-switch. And then in the multivariable analysis, the only one that remained significant was having a viral load of greater than 20 at the time of switch. But then when you look at having at least one viral load of greater than 50 after switching versus not, that's what this table shows over here. So 22 had at least one viral load of greater than 50, 122 had all viral loads less than 50, and you look at the multivariable analysis, what was associated was, again, whether or not they were less than 50 at the time of switch, but also, again, persistent low-level viremia pre-switch. And so in the multivariable analysis, having persistent low-level viremia pre-switch increased the odds of having at least one post-switch viral load of greater than 50, and the odds ratio was 4.6. And so, again, it starts to, I think, speak to this idea of maybe these issues of adherence and absorption or whatever resistance that is hypothesized to contribute to persistent low-level viremia may not be the issue that's leading to that, because it still seems that there is this trend continuing post-switch to injectables.
Lucas,
so, yeah.
Lalo has his hand up for a question.
Sure.
Hey, Lucas, this is a very interesting topic that we discussed, the theoretical reason. I wonder if, in addition to your linear models, classical multivariate analysis, you look at the trends, the permutations. In other words, what proportion of patients who were having viral blips went into the undetectable category, and vice versa, remain the same, stable, and that will probably make your paper stronger.
Thank you, Lalo. And I
It's a
think
plant.
that's what I think I'm starting to touch on this slide. So this is pre-switch and post-switch trends in viral loads. And so when we look in the pre-switch categories, 18% had blips, 18% had persistent low-level viremia, 4% had high viral loads, and 60% were always suppressed. And then post-switch, 22% blip, so about the same as pre-switch. There was lower percentage of patients with persistent low-level viremia, but still almost 10%. 2.8% had a high viral load post-switch, and 66% were always suppressed at less than 20. And so, yeah, when you look at kind of the pre-switch categories and then who falls into the post-switch, the persistent low-level viremia group, really almost all patients who were persistent low-level viremia post-switch also were persistent low-level viremia pre-switch. The highest rates of continual suppression post-switch, 75%, were also those that were always suppressed pre-switch. And then the blips also seem to be more concentrated in those that had blipped before switching as well. So yeah, I think exactly that starts to kind of get to the same point that I was mentioning. And, I think this figure was presented, I think, a couple weeks ago at High Rounds. And, I think this idea of what does contribute to persistent low-level viremia. And, I think there is data that supports that it may not be actual traditional viral replication, but instead, clonal expansion of infected T cells and producing low-level viremia. And it maybe, does make sense that, because I think we've all made a lot of efforts in the past for people with persistent viremia, adjusting their ART, intensifying, changing classes, all of these things, and it never seems to make a difference. And now we see that maybe switching to injectables in a certain population of patients also doesn't make a difference. And so I think that may argue for that idea that it's a different mechanism than just your traditional viral replication. So I did want to spend some time just quickly describing the one virologic failure that we had and kind of the characteristics of that patient. So she was a 42-year-old female who recently established care at the Owen Clinic in February. She was diagnosed with HIV in 1996 when she was 16. Has an unknown CD4 nadir, but no known history of opportunistic infections. She has HIV, hypertension, asthma, and arthritis. No issues with substance use, but when she did move, I think she moved from Atlanta. She was living in her car when she established care, was trying to find employment and housing. She does have a high BMI, so 37.7. And there's a list of her other medications. But for her ARV history, this is what we were able to piece together, mostly just from her report. We really didn't have much success getting outside records, but she was started on Cabotegravir in 1998 when she was pregnant, was on Truvada Reataz, not clear if it was boosted or not, and then Stribild, and the last 3 to 5 years has been on Genvoya. So when she came to clinic, she had expressed interest in switching to injectable Cabotegravir, and part of it was because of her social situation. She felt that it would be easier for her. She had no knowledge of prior resistance testing, so we did an archived genotype at the time. And her first viral load was undetectable at the clinic with a CD4 count of 907. So this is the result of the baseline or the archive genotype we did when she first established care. You know, for those of you not overly familiar with looking at these, you know, these are the different drug classes here, and then the reporting of the different resistance mutations in those classes. So you see she has a K103N. So there's a definite possibility that she potentially failed that Sestiva containing regimen that she had first started on, but not totally clear. And then interestingly, she also had a K238T mutation, and this mutation isn't one that's been on our radar. But maybe it should be, and I'll kind of mention why. But just keep in mind that, you know, K103N is not expected to affect rilpivirine, and was allowed in the clinical trials, the Cabotegravir clinical trials as well. And so when you put in, you know, that mutation combination of K103N and K238T into the Stanford database, and again, for those that aren't familiar with it, this is a database where you can put in resistance mutations, and it gives you information about the impact on different medications. You can see the rilpivirine score is 0, essentially meaning that it's expected to be sensitive. They comment on the K238T as being an uncommon polymorphic mutation that is selected in people on efavirenz, and usually is selected in combination with a K103N. And so it's not one, again, that we were paying much attention to, but after her case, and then it popped up on a couple other patients that we were evaluating for treatment on their archives. We did start digging into it a little bit more. There's really not much information in the literature about it, but this is a comment from the package insert, actually. And in the phase 2 trials, which were the latte trials, there were 2 failures that after failure had a K103N plus a K238T, and 1 patient also had a rilpivirine specific mutation. And so my guess is that these weren't selected out because they're not expected to be selected by rilpivirine, but instead were probably present at baseline. And I reached out to ViiV to see if they knew if those were present at baseline, and they didn't have baseline resistance testing for these patients, so or at least not with archives. And so it's just interesting that there were 2 patients that failed that did have that combination, and then our patient now also that failed that had that combination. And so this is kind of what her viral loads looked like. You know, she was undetectable in March. She started Cabotegravir in April. Her first viral load about 3 weeks after starting was 62. And then we had some trouble getting her in for repeat viral loads. And she had 2 injections. And then in August, her viral load came back at 1100. Interestingly, right before this viral load was drawn, or shortly before this viral load was drawn, she had decided to stop and go back to oral therapy because she didn't like the injections, but she had still not started oral therapy at this time because she had just received an injection a month prior. So once we saw this viral load come back in August, she was started on Simtuza, and we're still trying to get her in to repeat that viral load. But her injections for integrase. When you look, these are the summaries of the Cab and rilpivirine failures from Atlas and Flare. And this shows what NNRTI mutations were present at failure and what integrase mutations were present here. And then again, NNRTI here and integrase here. And neither of those mutations, including that integrase mutation, showed up at failure. And so when I finish with our last case, I'll show you again that we have another patient that may have selected that mutation with CAB. And so I do think that it was probably selected out by CAB failure. And the clinical impact on cabotegravir, I think, is still kind of unknown. There's, again, not much information in the literature. This is the R263K mutation that I'm talking about. This is in vitro data, and it shows the full change in EC50 for bictegravir is about 2.5 for cabotegravir, and 2 for dolutegravir. So again, kind of unknown clinical significance, but again, it'll come up at the end. So I was just going to finish in the last 10, 15 minutes or so about using Cabotegravir in non-adherent viremic patients. I think this is a hot topic for injectables, and we have a little bit of experience with it. Before I kind of go over our patients, there's been a couple studies published so far looking at this. This is the study from Monica Gandhi at San Francisco, and they described their experience both in suppressed and viremic patients. So they enrolled patients with or without viremia who were willing to receive injections, attend their regularly scheduled visits, resume oral ART if treatment was interrupted, and provide a reliable form of communication. And they excluded, of course, those with rilpivirine-associated mutations. Patients that were referred were reviewed by a clinical pharmacist and then scheduled with the pharmacist for education and counseling. And they have a pharmacy technician who manages insurance authorizations. So that kind of exactly mirrors the practice that we have here at the Owen Clinic. Viremic patients kind of developed individualized plans for adherence to their injections. So they involved case managers, home and street-based nursing. They looked at community-based injection sites, and then also did provide financial incentives for visits or blood draws. They did a follow-up phone call 7 days after the injections by the pharmacy team, and they had their pharmacy technician doing appointment reminders and missed appointment follow-ups. So again, mirrors what we do here. They did viral loads every 4 weeks until they were undetectable, and if their second injection they were detectable, they did resistance testing. And they did do monthly injections until they were suppressed for 6 months, and then they could switch to every 2-month injections. So these are the kind of the demographics. I think some things to point out: 20% Black, 39% white, 90% male, cisgender male. They did have over 50% with current stimulant use, and 33% with unstable housing. So just focusing on the patients that were detectable at the time of switch, the median CD4 count in those patients was 99. So these were people with more advanced disease, and the mean viral load was 4.67 logs. All their patients went direct to injection, and their follow-up was a median of 6 injections. So 12 out of those 15 did achieve viral suppression. 3 of the patients that had not yet got suppressed did have a 2-log decline in their viral load at the median of 22 days. And so for the total cohort, 87% had on-time injections. And they demonstrated kind of in their 15 patients the viral load trends and how long they took to become undetectable. But they did identify some characteristics that they thought were leading to success of their program. One was they actually did in-person outreach for 2 patients who missed their injections. So basically went out and found the patients. They did comment they had 2 patients that had been detectable for over 10 years and never achieved viral suppression that were able to get suppressed. They have what's called the pop-up clinic, which is kind of a low barrier drop-in clinic. And so they had scheduled injection days that allowed drop-ins for their injections. They commented about the importance of having a bilingual pharmacy technician to facilitate retention. And I definitely have to give kudos to our pharmacy technician, Elvia, who's also bilingual and does similar work. And then they did comment 1 patient was receiving injections via mobile harm reduction van in partnership with Department of Public Health and street-based nursing. And thanks to Shannon for sending this paper to me that was recently published that evaluated the compassionate use program through ViiV. And they looked at patients' eligibility for the compassionate use program were patients who had a need for parental administration due to malabsorption syndrome, dysphagia, or psychological condition preventing oral therapy, and then progressive disease. So through compassionate use, they were provided every 4-week injectables. They were required to have good retention and care. And of the 35 patients who were included, 28 had detectable viremia at enrollment, and 80% of those had CD4 counts of less than 200. And at the time of data cutoff, they had 16 out of 28, or 50%, that achieved viral suppression. And the median time to viral suppression was 5 months. But they did have 6 patients that were detectable at entry that discontinued due to incomplete virologic response, 2 of which achieved undetectable viral loads and then had rebound. And all 6 of those developed new NNRTI resistance associated mutations, and 3 out of the 6 developed INSTI mutations. And they did comment that 3 out of the 6 had high BMIs. And so there was no information in the paper about adherence to injectables and if patients were getting their injections on time, but slightly different results in a similar difficult to treat population. And obviously there's the concern that patients did break through or didn't get suppressed and did develop resistance mutations. So this is just a table of a summary of kind of our experience in using this in patients who have been viremic. I'm not going to go through each individual case, but I did want to point out a few. We have this patient here who's a 61-year-old male who really was not adherent just due to a chaotic social situation, was on Biktarvy Prescobics. We, shortly before switching, had him start coming in weekly for pillbox fills, so was able to get his viral load down to 228 before switching, but it was between 228 and 732,000. In the year prior, his CD4 count was 92, and it had been since 2014 since he's been undetectable. So he started injectables in May, and his most recent viral load was undetectable in September with the CD4 count up to 169. I wanted to mention this patient, a 38-year-old female with methamphetamine use and other social difficulties with her social situation, was on Biktarvy with a viral load of over 12,000. Her CD4 count was 264. And so for her, we actually started Rilpivirine in combination with TAF-FTC and asked her to try and do her best to take oral therapy as long as possible to help, with driving down viral load. And so far, her most recent viral load was 40 copies in September, and her CD4 count increased to 394, and we stopped the TAF-FTC in September. This patient, a 38-year-old male with recent PML with methamphetamine use on Biktarvy. Shortly before switching, he had been hospitalized, so his viral load had decreased down to 82. But his viral loads ranged between 82 and 1.5 million the year prior, and it's been since 2012 that he's been undetectable. He started in May on injectable Cabotegravir. 1 month after the switch, the viral load actually was up to 198. So we added TAF-FTC at the same time. He actually did a pretty good job of being adherent to that. And now his most recent viral load is down to 57 copies. And then I wanted to point out this patient, a 24-year-old female who has been able, due to childcare and work, unable to really stay adherent to oral ART, also on BF-TAF with a viral load of 51,000 and a CD4 count of 92. And so we had her start Cabotegravir in September and had her try and take Centuza at the same time as best she could. And 1 month after switch was undetectable and stopped Centuza. And then I just wanted to kind of finish in the last 5 minutes about this really interesting and challenging case where we tried to start going the route of parenteral therapy for someone who's really been unsuccessful in taking oral ART. And maybe with questionable results so far, but this was a 38-year-old cis man with HIV/AIDS. He was diagnosed at age 2 after a blood transfusion, also with diabetes, obesity, hypertension, and had PML diagnosed in 2013. So he's got a long history of non-adherence to oral ART. due to GI intolerance, mostly to boosted PIs. He really refuses to take boosted PIs anymore, and feels that the medications make him depressed and fatigued. These are CD4 trends over the last 10 years, essentially progressive decline in his CD4 count now into the double digits, and his viral load trends. So you can see a few undetectable viral loads, but mostly viremic, especially recently. I'm not going to go through his full antiretroviral history, but he's been on many different salvage regimens, many different ART combinations. More recently, he's been on an INSTI and an NRTI PI combination, but really hasn't taken it very much, and has mostly been off of therapy due to side effects. He's had a couple resistance tests. The takeaway is he has a significant resistance. The NRTIs are compromised, of course. The NNRTIs, he has major NNRTI mutations, L100 and Y181. So the class in itself is mostly not going to be in play. Integrase is the one class that's fully sensitive, and then the PI Darunavir is sensitive, but not something that he's really able to take. This is an old phenotype that he had that shows sensitivity of the different medications. And the reason I show this is despite even more NRTI mutations being detected on the phenotype, tenofovir is something that remains sensitive for him. And then the Stanford database interpretation of his resistance is pointing out that all the NRTIs have significant resistance, although again, we expect tenofovir to have activity based on the phenotype. All the NNRTIs are expected to be resistant. And then for the PIs, he does have activity with Darunavir. So because of his inability to really successfully take oral ART, and his CD4 count down to 12 and high viral loads and his history of PML, we decided to try and put together a regimen for him with Trogarzo, which is a monoclonal antibody infusion every 2 weeks. Because he's resistant to Rilpivirine, we went with just injectable Cabotegravir every 2 months, and then asked him to really try and take just Descovy because he has tolerated that in the past by itself. And so we started in May when his viral load was 80,000 copies. He had a good initial response down to 356. And these are his Trogarzo infusions along with the every 2 month Cabotegravir. But then really didn't kind of achieve suppression and had a rebound in his viral load. And then in July, viral load was 723 with minimal change in his CD4 count. So we did a pheno GT plus integrase when the viral load was 723. And I think a few interesting things to point out. One is, if he really was taking TAF FTC, we know he has an M184V. You would expect an M184V to show up. So it makes me think he was telling us he was taking his oral Descovy, although either he may have been forgetting or not actually taking it. Not totally sure. Despite all of his NNRTI resistance, Doravirine's actually phenotypically active. So that's at least one other agent that's still active. And then what we see, is this, again, R263K mutation. And we were trying to figure out, is this, because that's really mostly been reported in people who've been exposed to dolutegravir, and he has dolutegravir exposure. Was it already there, or did this develop because of his injectable CAB? And based now on the patient I presented previously that failed, our guess is that again is something that developed on injectable CAB. And you can see this actually shows phenotypic data for the integrases. And it's very similar to that in vitro data that I showed, which is around a 2-fold change for bictegravir and dolutegravir. And there is no Cabotegravir included in this. And so based off of those results, we intensified his regimen to Trogarzo. IM Cabotegravir was already on board. And so then we had him start trying to take oral BF-TAF and Doravirine. Kind of as would be expected, a month later, he reported he stopped his oral medications. He just didn't feel good taking them, he said, and didn't like the pill size of the Doravirine. So we did convince him at the end of September to at least just try restarting BF-TAF. And you can see these are the viral loads since then. So again, kind of hanging out around 1,000 to 2,000 copies. This one most recently drawn was better at 185. And we actually had Monogram do phenotypic sensitivities on Cabotegravir. And they were able to send us this showing a 2.3-fold change in Cabotegravir activity with that INSTI mutation. So I think it's still questionable how much that's going to affect Cabotegravir clinically. It seems it does. And I think Bictegravir may be more active in this situation, but the problem is that he has to take oral therapy. So we did get approval for expanded access lenacapavir for him. He's likely going to be starting that next week, and hopefully continuing on a mostly injectable regimen. So in conclusion, majority of patients who initiate Cabotegravir do remain on therapy, with about 10% of our patients stopping. Those with persistent low-level viremia or detectable viral loads pre-switching seem to be more likely to have detectable viral loads after switching. I would be cautious in switching patients with prior efavirenz failures. I think it's going to really take a deep dive into their clinical situation as well as their resistance history. And I think we're seeing mixed early results using off-label use in patients with poor adherence and viremia. I think I'm kind of on the fence if this is a strategy that's really something that's going to work well. I think it's important to point out that both Cab and Rilpivirine have low genetic barriers to resistance. And our successful 2-drug regimens always have an anchor drug that's a high barrier drug. And so it probably will work for most, but I do think there's a likelihood of seeing failures with resistance as a possibility. So I want to give a big thank you to the whole Owen Pharmacy team, Carrie, Jeff, and Christian. Elvia and Alan, our pharmacy technicians, who are hugely important in this whole process of injectables. Medical Offices South Pharmacy, who fills the majority of our Cabotegravir Rilpivirine. Our Owen Clinic nursing staff, who does all of these injections. It's a lot of gluteal injections all the time, every day, and they do a great job with it. And then Nimish for his help with our statistics, and Stephanie, our pharmacy resident, who also gets kudos. She got a Young Investigator Award at Croy this year for our Virologic data research. So with that, I'll take any questions. Thanks.
Thanks, Lucas. Just keeping an eye on the time. There are a couple questions still in the chat, and I'm sure other people may unmute themselves. They both began with, sorry if I missed this. So Robert Dice asks, what is the frequency of viral load monitoring after a switch to Cab Rilpivirine, and is it more frequent for patients with a long history of treatment?
Yeah, good question. We're generally checking viral loads 1 month after switch, and then often again 2 months later, and then back to kind of the every 3 to 4 month viral load monitoring. We will only generally increase the frequency if we see unexpected blips or viremia. It does get a little challenging because I think I pointed out that we do relatively frequently see blips or persistent viremia post-switch. So deciding how frequently to check and if it's a viral load of concern is sometimes not always an easy decision. And the other piece is, these patients come in for nurse visits for their injections, and we ask the nurses, and I know they always do, whether we want them to go down to the lab or not for a viral load after their injections. And despite asking, a lot of times it doesn't always happen. And so, it's also a matter of getting the patients to do the more frequent monitoring.
Okay, and then, thank you. I think John Guatelli asked, what was the HIV subtype of the woman who had the virological breakthrough?
She's subtype B.
B, okay.
Mm-hmm.
Which was different than what was seen in...
Well, yeah, a predictor of failure in the studies was subtype A6A1. Okay. And so, yeah, she was the expected subtype B.
Okay. I think this is something you and I were just starting to chat about the Glasgow presentation of the HPTN 083 CAB PK concern. Maybe this wasn't exactly, but sorry. So Ryan Racino asks about the Glasgow presentation of HPTN 083 CAB PK. Does that concern you at all in terms of on-time injections?
Ryan, do you want to expand on that?
Sure, can you hear me?
Yeah.
Yeah, so Rafi Landowitz presented data at Glasgow, laboratory analysis of HPTN-083, and there remains unexplained case of patient that's seroconverted in spite of on-time CAB injections and adequate PK concentrations. And there's also concerns about people that have certain characteristics having altered PK where that trough concentration falls below a certain point. And given that we don't know exactly what those predictive factors are to an extent, I mean, obviously BMI is one of them and past resistance is another, and the subtype that you mentioned, I'm just wondering if there are certain situations where you are a little bit more concerned than in others, and in terms of these people developing lower than usual trough concentrations.
Yeah, I mean, I think it's a good question. I think, and I didn't include it, but they did recently, I think it was also at AIDS, update the data on the predictors of virologic failure now that the phase 3 studies are out, I think 3 years of follow-up. And again, the focus of those that failed was, having either high BMI, the strongest predictor was rilpivirine resistance at baseline, and then the subtype A6A1. But it seemed, I guess, approaching this, you can control what you can control when you decide what patients to start on this therapy. And, out of all of those predictors, it was those that had 2 negative predictors that had a 20% failure rate. If there was only one of those predictors, then it was only a 2% failure rate, I think. And, I think probably related to issues with PK is also the issue of BMI. So what I'm getting at is, I think that one of the most important things is doing due diligence of ruling out baseline rilpivirine resistance. And that's both through clinical histories and doing resistance testing when it's appropriate, to ensure that that's one factor that's removed. So if they do have these other negative predictors, as well as potentially unexplained or unanticipated low concentrations, hopefully that still doesn't lead to failure, if that makes sense.
So just in the interest of time, I mean, I want to give people some time back. There was a question about low level viremia and what that means. I think that's a big topic that probably could be discussed other places. And I think there are a few other questions. I think at this point, y'all, if you have questions, I think it would be emailing Lucas directly about them, because I think they're all sort of bigger topics to explore. And I think this is incredible, Lucas. I know you're going to sort of become the de facto expert on this, and I think we hope there'll be more and more data. This real life data is so important, because I think we've all now have our anecdotes of patients where something has gone awry, and I think having more and more of these things will be really interesting. Sorry, Shannon, not going to answer that. I don't know why people are still putting in their questions. If you want to take that and send that over to Lucas, we're trying to give people a little time back at the end of the day. So I see. All right. Lucas, if you want to blurt out your answer. Oh no, it's 9 o'clock.
Shannon, we can chat. We can chat later.
All right, everyone. Have a great day. We'll see you next week. Or not next week. We're off for the holiday. So I believe we're off for the holiday. I hope we're off for the holiday.
Yeah, I don't think anyone.
Yes, we are. I don't think anyone's
right. It's Dr. Wooten's on the 18th. Is that correct?
Yes.
Okay, great. All right. Bye, everyone. Have a good day.
Bye.